Dr. Siddiqui, before you leave, I want to make sure to get your thoughts before we wrap things up as well.
I've got a question, Tom, too, is that in Europe, how does CGuard stack up? What is its market share, and what can we all learn from the fact that it's out there competing with these older stents? Where is it doing well? Where is it not doing well? And then Marvin, it's for you. Explain that to us.
So I've got in my shelf, I've got 3 types of stents. Can I name them?
Of course.
I've got Casper, carotid wall stent, and CGuard. So Casper, we call it Road Saver in Europe. Wall stent, I think they'll all go back to the producer. We don't use wall stent anymore. Casper is used very, very rarely because I don't like the maths you've got to do to understand how long it will be. So my first choice stent is CGuard. And the people I talk with, my colleagues who practice stenting, use CGuard. So I think CGuard is for all the reasons you just said, it's flexible, it contains the plaque. It not only contains the plaque, but it contains ulcerations as well. I've got some cases in which in the final angiography, you see the dye that remains in the ulceration, and you know the emboli will remain there as well. So with a first generation stent, that would be an embolizing issue, and a profound ulceration. And when you talk about calcification, I've been to a meeting lately, and they started using these special balloons to fragment the calcified plaque. You feel quite confident doing that with a proximal protection, because I imagine that could generate quite a lot of debris. So calcification will not be an issue in the future, in the near future. So the difficult question is the one Marvin asked at the beginning. What will the transition from stenting to from open surgery to stenting be? Why are vascular surgeons some way allergic to stents? At least in Italy, in my group, we're 10 surgeons. 3 of us use carotid stents. 7, it's against their religion some way. Okay.
Yeah, I think TCAR has sort of changed their approach, really. It has opened up, and now TCAR is rapidly growing. I mean, they went public based on widespread acceptance by vascular surgery. But CGuard still doesn't have the lion's share of the market in Europe, does it, Marvin?
Yeah, I think, you know, we see our market share across the board. It's somewhere in double digits, depending on the market. In Italy, you know, it's the bellwether for us. We think that we have about 36 to 37% of the market. There's sort of 2 things pulling on that. One of the economics are very different, right? It's a DRG based system. There's a lot of tenders that are created. It's not a favorable environment, nor is it evolving into a favorable environment for innovation. I mean, the reality is that it's just not. It doesn't reward innovation in many ways from an economic perspective. But we compete and try to compete on that level of data. We've got 5-year data now on CGuard. We're 36,000 stents into our sales overall. So it's a really important topic for us. But you know, I think it's a very, very different market. But part of our investment in a TCAR delivery system with SwitchGuard is really for that purpose, because right now we play in a total market in our served markets of about 40,000 CAS procedures, right? When there's about 290,000 treatable available. So we're still trying to climb that wall of surgical conversions to CAS, right? I think we do well in the smaller sandbox, but we got to make that bigger.
So I agree with Adnan that I think the allergy to carotid stenting has been mitigated a bit by TCAR, and so to that we owe TCAR the delivery of the acceptance on the part of many vascular surgeons where before they weren't. I mean, I can speak to some at Mass General who were absolutely allergic to stenting and now are, embracing stenting using TCAR. But I think that will also, that means stenting's okay. And leaving a metallic implant is okay. And now that's generally much more accepted in the carotid. They've always accepted it in the abdomen and the pelvis, but now it's okay for the neck as well. And I think that's going to play. The other thing to say is in Europe, my understanding, and I don't know the data, but your sales are increasing.
Yeah.
And I think the market share is gradually increasing. I think the momentum and the excitement that happens when CMS, hopefully, when we sort of move to the next level, will actually enable a rise.
And from the investor standpoint, I would say there's a difference in the European market. And let me explain. Not any, but they're willing to use a wall stent in
Right.
Europe for some reason.
Right.
I want to ask anybody at this table who does carotid stenting the last time you used a wall stent. They're not on my shelf. You need a slide rule to calculate how long, where to put it. All right, and one, but you're not in this room, Adnan, so keep your hand up. The bottom line is Joe America is usually not going to use a wall stent. Okay, and and the reason you now use it now, Adnan, number one, you're very skilled and you can figure out the slide rule that I can't. But you need closed cell coverage for some of the plaques that you treat. Okay, so when you have this stent available, your wall stent, my prediction would be, okay. And as mentioned earlier, unlike the Casper as well, or the Road Saver, whatever we're going to call it, we were in that trial. We put a lot of people in that trial, and it would go this long. So you didn't know how long it would end up. A CGuard 30 is 30 millimeters long. By the way, a CGuard 40 is 40 millimeters. The math is pretty simple, even in Tennessee. So the point is now,
Not that difficult. It's not that difficult, Chris. You just look at it and you kind of say, that looks like an 821 to me. It's not that difficult. You just gotta close your eyes and feel it. What's wrong with that?
Very
so this
scientific.
is the world one of the world leaders here for the investors telling you the method of preparing.
We won't write that into the IFU, okay?
You do this and you just kind of put it together. So the point is,
I'm sure he's never said that to a trainee. Just close your eyes and feel it.
I've been up there as a trainee up there. I can promise you he never said anything close to that. But the difference in the Europe is that they are willing to do a wall stent in the marketing in the DRG. That it's a little different. In the United States, we're not going to use a wall stent. We're not going to use some of the others, and the other older ones. This new stent will compete extremely well again.
Right. So I think in general, Dr. Siddiqui, you pointed this out. In general, we have to hold a higher standard and we have to create a different standard. And we're trying to do that with CGuard. And that's difficult, right? Because, when you're playing at a certain level, an expectation of a carotid stent hasn't had the greatest reputation over the years. And so when we work on data and we have 5-year data now and 1,850 patients enrolled in studies, we're trying to set that new standard of care expectation that 1.1% complication is what you should expect, not somewhere between 5 and 7 and hope for the best. And so, that's a tough one, frankly, in the European setting, because many times cost of the devices becomes the driver more than, is
But
it
you
really
hit the market through the US market with a head-to-head comparison against a legacy stent. Whereas, in the endovascular arena, there's except for the coronaries, there's so little head-to-head comparisons. We've seen a few in the lower extremity in the last couple of years, but for the most part, there's zero. And so, we've already seen where we can go with the current technology that's available to us today. We've seen with what's been reported for the CGuardians to be improved. And I think we've all seen it as part of the trial in the cases we've done, but you guys have head-to-head data comparing two devices, one commercially available in the United States and one, the CGuardians. And so you already will hit the market with some data to speak, saying what's the difference between the old platform and the new platform. And there's nothing we have today, say it over and over again. After I close the groin or I close my neck for TCAR, I have nothing after that point. My patient wakes up to protect them for that stroke that happens between that point and 30 days. And this does, I mean, it also helps with the intraprocedural plaque. So it's helping on the two areas we know are the most highest risk. We have nothing that hits the whole second half of that equation.
Great.
But that's the origin of the ACS2 says that stenting, everyone knows what ACS2 says, but it's considering tens of different protection systems.
Or very
Ancient
few, or
stents.
27% of people use the protection system of the 10 different ones, for crying out loud.
Yeah,
But
okay,
anyhow,
and different stents, open cell, closed cell, double layer stents, and the results are comparable to surgery. I wonder if you use the best protection system or access route and
the best stent.
the best stent,
Mhm.
what will the results be?
We're thrilled that you guys are believers, and we'll continue to work our hardest to make sure that we honor that, and that we go forward that way. Dr. Siddiqui, any final thoughts? We know it's getting late in Buffalo. You've been traveling. Well, your frequent flyer miles
I
are.
need to get my snowmobile out tonight, maybe. But one question I have is for Tom, with your experience, when do you think this is not a good stent? And I'm not talking about a heavy calcification environment right now, which hopefully with things like shockwave and other technologies will also become. But leaving that aside, is there a situation where you say, I probably shouldn't use it? Or is there a drawback to this technology that we should be aware of?
My religion forbids me to give you an answer. So yeah, there is. It's the very tortuous access route.
Okay.
Very tortuous access route. I expect with the new delivery system, this issue would be addressed. But very tortuous, common carotid, type 2 arches, type 2 arch, tortuous common carotid. You'll have quite a lot of friction in the system, but that's a drawback for the stent, but not necessarily a drawback for stenting, because if you think you want to treat that patient with a stent, in that case, only in that case, you can use another stent. The important thing is it won't have the same outcome in time, it probably. But you're in a situation in which you've decided that that patient is a high-risk patient for surgery, okay? So you've decided that patient needs a stent. You can't do, or at least the cut down would be at too high risk. So you've decided you have to operate him. You have your CT scan, your pre-op CT scan. You know it's going to be very torturous. You can choose something else. But your mentality tells you, I want to put a stent in that carotid artery. So that's what's the most difficult thing, I think, is for you to convince the vascular surgeon that there is an option for stenting.
So with the new system, would that make it more favorable for such tortuous anatomy as well?
We hope so.
We hope so.
The new transfemoral delivery system called CGuard Prime, Dr. Castrucci has seen it. Actually, we're all going to see it this evening. It's built on a very different platform and delivery handle and flexibility of the shaft of the catheter. So we hope that addresses that situation and makes it more usable in acute situations in particular. So that was the investment in the transfemoral side. And then of course with TCAR, with SwitchGuard, to the extent that you want to choose a different route. We'll even hear tonight a bit more from Dr. Castrucci about his innovation with using a Stryker flow gate balloon transfemoral reverse flow, which is
But Adnan said very interesting things. I love what you said about version with common carotid artery clamping.
Yeah, it's no need for external balloon. We used to do MoMA, but the problem with MoMA and stroke is that you can't get intracranial with anything big enough. So you got to take MoMA out and go back up with something else. And so with an 8 French balloon guide, we did TCDs, but I'm a strong believer in proximal protection. This guy Chris brought me into the fold with MoMA, but I think now that fixed ratio restricted lumen with MoMA becomes a problem with, tandem intracranial stuff. So we've just gone.
And another thing, the tortuosity issue, it happened once in 180 stenting procedures. So it's,
When you say it happened, it was a non-deployment?
it was a non-deployment.
Yeah,
But
but no
not-
harm, but just you.
No,
couldn't-
no, I just took it out and I think it was.
But assuming you're doing 6 French, and with Adnan, he's using an 8 French loop guide,
Mhm.
which is not going to have that issue because you have a bigger inner lumen.
Right.
Absolutely. 8 French. And the other thing I have to tell you with the balloon guides is in tortuous access, it becomes a real godsend. So flow gate is not really very good. It doesn't deal with tortuosity well. We use this balloon guide, Walrus, which the new balloon guides. You inflate it wherever it is, and now you can put your distal access catheter and wire, and really, it really locks it in. So I just love balloon guides for carotids now.
It gives us stability as well.
Yes,
Chris.
exactly.
Dr. Siddiqui, thank you. Thanks for joining us.
Thank you, guys.
Wish you were here. Next time, we'll save you a seat.
I hope he'll be buying you a nice dinner at least.
We will. We'll send you pictures. But
Oh.
thank,
Dogs.
Send us pictures of your snowshoes.
yeah, send us
I
this.
will. Bye-bye. Thank
Thanks
you.
for joining us.